So let's understand some points on nephrotic syndrome. So, as you know, nephrotic syndrome, consider this is afferent arteriole. This is the unit of kidney. Okay, consider both kidneys as this one unit. This is the afferent arteriole. Okay, from this filter where the product comes from the kidney is nothing but our urine. Okay, what happens in nephrotic syndrome is that this urine contains more than 3.5 grams of protein per 24 hours. It's important. Others are there is hyperlipidemia and hypoalbuminemia. This hyperlipidemia is due to excessive production of liver proteins to compensate the protein loss. Why this protein loss occurs in nephrotic syndrome? Let's understand. This barrier which every blood component should go through before joining the efferent arteriole contains three important parts, that is podocyte, foot process, and there is a basement membrane, and there is epithelium. This is podocyte foot process with endothelium, and here it is basement membrane supported by one supporting cell known as mesangial cell, and this is epithelium. Okay, from these three barriers urine should go out. So if there is a problem in this barrier, the proteins are lost in urine. Happens in nephrotic syndrome. This nephrotic syndrome has four important components. First one is minimal change disease, next one is membranous glomerulopathy, third one is FSDS, that is focal segmental glomerulosclerosis, and last one is MPGN. Let's understand what is the important pathological changes in these three things. Okay, first one is minimal change disease. Word itself says there is minimal change in the foot process. Minimal change in the foot process. But foot process is still intact. This intactness of foot process with minimal damage causes something known as selective proteinuria. Selective proteinuria. Then what happens in membranous glomerulopathy is because of some disease systemically, there is deposition of antigen antibody complex subepithelially. So subepithelial deposition of antigen antibody complex causes membranous glomerulopathy. What happens in focal segmental glomerulosclerosis? Here complete destruction of podocyte, okay, or massive destruction of podocyte resulting in non-selective proteinuria. Non-selective proteinuria. Non-selective proteinuria. So this selective proteinuria is only for albumin, but here in FSTS there is non-selective proteinuria, means along with albumin there is loss of antithrombin 3, protein, yes, ceruloplasmin, ferritin. So this indicates a severity of proteinuria. This is a less severe proteinuria. What happens in MPGN is minimal change, membranoproliferative glomerulonephritis. Just observe the word P, that is there is proliferation. What proliferation is? Proliferation of this supporting cell or mesangial cell proliferates excessively. Okay, along with this there is antigen antibody deposition. So excessive proliferation or proliferation of mesangial or supporting cell causes MPGN. Important point on MPGN is, remember, its presentation. Okay, presentation. It is the one odd one out in the spectrum of nephrotic syndrome, because all these three things are completely within the spectrum of nephrotic syndrome. MPGN stands between nephrotic syndrome and nephritic syndrome. Okay, it is considered within the spectrum of nephrotic syndrome, but it presents as if it is a case of nephritic syndrome. So, let's understand some points on their presentation and their important points. First one is minimal change disease. Points on minimal change disease. Minimal change disease. Minimal change disease most commonly occurs in children, and very important point is here there is no risk of CRF. That is, there is no risk of CKD. There is no risk of chronic kidney disease. Hence, it is having very good prognosis. So, to understand in a broader term, the risk of CKD increases as you go down. That is, when minimal change disease, there is decreased risk, and in MPGN, there is increased risk. Same with the hypertension. Here, there is no hypertension. That is, minimal change disease, there is no hypertension. As you go from minimal change disease to MPGN, there is increased hypertensive episodes. Hence, MPGN presents with hypertension, minimal change disease, there is no hypertension. Same as in case of hematuria. Hematuria. In minimal change disease, there is no hematuria, but here hematuria presentation increases as you go down. Same with the treatment, steroid response. Minimal change disease is very much steroid responsive, hence having good prognosis and decreased risk of CKD. But MPGN is having a resistance or very much steroid non-responsive. They are non-responsive to